I would like to welcome you all to the webinar Key Updates in the Lung, Breast, GI Cancer on 18th October, which is under the Society SOMAX, and the convener is Dr. Vikas Sasati sir, Consultant Medical Oncologist, Sri Aurobindo Institute of Medical Sciences, Chittoram Hospital and Research Center, Indore. I would like Vikas sir to invite the following proceedings, sir.
So, good evening, everyone. Hope I am audible to everyone.
Perfect, sir.
Yeah. So, as you know, that medical oncology is one of the important branch of in medicine where the data is coming on almost regular basis, and the data is being updated. So, it is important that we update ourselves on regular basis, and the primary motto is to give the optimal treatment, the best possible treatment to our patients. So this symposium is one of the small steps to achieve that goal. So we have a few lectures from different faculties, and we will be discussing about the lung cancer, one of the important abstract from the GI and also from the breast. So let's start with the lung cancer, and for the first presentation, we have Dr. Deepak Kopakka. He is one of the best friend of mine. He is currently working as a consultant medical oncologist at Care Super Specialty Hospital, Hyderabad. And one thing that I can say about him that if I have a problem in managing lung cancer, I think he is the person whom I always contact. And I am very sure that we all will be benefited with his knowledge today and even after that also. His topic is about the choosing essential biomarker on NGS, not only in the advanced stage, but also in the early stage. So I request Dr. Deepak to continue the first session.
So I would like to thank Dr. Vikas for his very kind words, and yeah, we've been very great friends and very close group of friends from our DM days, and we've learned a lot from each other. And I would also like to thank the organizers for giving me this opportunity and allowing me to speak on a topic that is very close to my heart. So yeah, I'll be talking about choosing essential biomarkers on NGS in early and late stage lung cancers. And I think all of us are already doing this in our practice, and this is just to highlight a few points that I thought should be brought forth to the team here. So yeah, so the contents for today's meeting would be about lung cancer in India, and I will briefly present about our data that we have analyzed over the last 3 years, biomarker testing and NSCLC, evolution on how the testing has happened for evaluating various biomarkers. I would like to discuss, and the takeaways for our day in day out practice. So lung cancer is one of the commonest malignancies, and it's among the top 5 malignancies across both sexes. And in men, it is the second most common malignancy, with nearly 72,000 new cases diagnosed every year. And it is one of the leading cause of cancer-related deaths in India. So this is what is the data that the pie chart that keeps evolving every year. This is the data which says around 50% of lung cancer patients end up harboring mutations, the commonest being EGFR, followed by ALK, ROS, and the rest account to around 2 to 3% mutations. We've just analyzed our data, and we were surprised to see that around 70% of the patients end up harboring mutations, and this also includes KRAS mutations. So significant proportions of lung cancer patients have actionable mutations, and it's very important that we end up doing the right method of diagnosing to identify biomarkers. And why is this important? Why do we really have to search for biomarkers? There are various reasons. The most important reason being the survival significantly improves if the patient receives the targeted therapy for the driver mutation the patient harbors. So one, the patients live longer if they end up having a driver mutation and when started on the appropriate treatment. Second, these treatments have lesser side effects, lesser toxicities than conventional chemotherapy. Third, these most often than not, these treatments are treatments that are pills, except for the HER2 space or amivantamab that we use in EGFR exon 20 insertions. Most of these treatments are pills, so that improves the quality of life, and the patient can take these treatments at home. And obviously, longevity is the major driver for using these treatments in practice. So these are the regular mutations. One mutation that we missed in this chart is the HER2 mutation that has a recent US FDA approval for trastuzumab deruxtecan in this space. But across most other treatments, except for KRAS and HER2, we have treatments available in India either on per purchase basis where patients end up buying the drug, or on compassionate access basis like the RET1 mutations or the NTRK gene fusions. Most other treatments are available for drug purchase for the patient. So eventually we end up having most of these treatments. KRAS, both adagrasib and sotorasib are currently not available for purchase for patients. And trastuzumab deruxtecan probably will be having the drug available for use from next year. So how do we use this? Is a brief the flowchart on what are the mutations that we check, what are the techniques that we use. So DNA sequencing, whether by NGS or PCR, is easy for us to detect insertions, mutations, and deletions. So as we all know, EGFR, KRAS, BRAF, HER2, MET. Again, I would like to discuss that in detail, but these 4 mutations, I think a DNA sequencing either by a PCR or NGS is required. What is the advantage of NGS over PCR? The depth of sequencing is higher. We end up identifying mutations, particularly the exon 20 insertions in EGFR. NGS helps us identify more mutations than PCR because whatever probe that we use needs to identify those mutations. So around EGFR by NGS for exon 20 insertion, we end up identifying more mutations with an NGS because the probes that we use only identify around 8 or 10 EGFR 20 insertions for when we use a PCR based method. Now, RNA sequencings are really good for fusion detections. ALK, ROS, RET, NTRK, these are all fusion proteins. Now there is one more fusion protein that's actively being researched, that is NRG1. Currently, there are drugs that are in pipeline for this mutation. Probably over the next 2-3 years, we'll even have that fusion protein for this. But RNA sequencing particularly helps us identifying fusion abnormalities. It's one of the most sensitive method for identifying fusion abnormalities. And also for MET exon 14 splice variants, there is a splicing of exon 14 that happens that leads to a fusion of exon 13 and 15. For that also, RNA sequencing is more sensitive than a DNA sequencing. So for these 5 fusion abnormalities, ALK, ROS, RET, NTRK, and MET, an RNA sequencing panel would be an ideal panel. Now, these are the things that most patients, not most, but patients can afford. But in situations where patients' affordability is an issue, at least a PCR for EGFR analysis and an IHC for ALK are required. IHC for ALK is actually very, very sensitive. It is actually more sensitive than a DNA NGS sequencing, probably equivalent to an RNA sequencing. ROS by IHC, that needs to be confirmed by a FISH because IHC is not very specific for ROS1 abnormalities. IHC is widely used for PDL1, and it is the only modality that we currently use for identifying PDL1 expression. Either a 22C3 platform or an SP263 platform have a concordance to the tune of 80 to 85. 80 to 85%. So evolution of biomarker testing, what is the past and the current? So it all started with a preliminary diagnosis where lung cancer diagnosis is started by either a tissue or a cytology-based method. For tissue, we either use more often than not in stage 4 cancers, we use an excision biopsy of the lymph node or a core biopsy, either USG guided or CT guided. Other than that, FNAC was used at one point of time, rarely used now, only in situations where we just need to identify the malignancy or exfoliative cytology where we identify malignancy on pleural fluid or CSF analysis or sputum rarely. Most often than not in lung cancer, because we always cherish that more tissue we have, better is a diagnosis. We end up doing a tissue biopsy rather than using cytologies. But in cases where, for various reasons, cytology is the only way of establishing malignancy, we end up identifying mutations by a newer technology called liquid biopsy. Now, with liquid biopsy, most often we use blood as a sample, but there are recent labs that are also using pleural fluid as a method for liquid biopsy for identifying tumor DNA and then running NGS over it. Now, once we have this, we either prepare an FFPE block from the tissue or cell block from cytology materials that we have. And then we use this for either histology or cytology. And parallelly, we use IHCs on cell blocks or on FFPE blocks for identifying PDL1s. In some situations where the patient is really sick and we can get an ALK diagnosis overnight, we do IHCs. After this, if the patient does not have any ALK or we want to move forward, we either do an DNA sequencing like PCRs that we've been using over a long time for EGFR mutation analysis for BRAF, or we can use a next generation sequencing. But again, like I told earlier, DNA sequencing probably is not very ideal for fusion abnormality detection. So an RNA sequencing is an ideal methodology. RNA NGS is an ideal method for sequencing, for identifying fusion abnormalities. Proteins like PDL1 expression or ALK overexpression can be done by IHCs. So biopsy is an ideal method, but again, in some scenarios, we find it very difficult to get tissue biopsies or adequate tissue sample. Most often we encounter these situations where the patients present with a lot of pleural effusion, thoracoscopic biopsy, the patient might not be suitable for a single lung ventilation. The other scenario that we frequently encounter is patient having a very small lung mass with extensive bone metastasis. Tissue biopsy, though, helps us identifying the diagnosis, whether it is squamous or non-squamous. For biomarker testing, we need a good sample tissues, adequately processed tissues. And once we have this, we can do EGFR, ALK, ROS, NTRK, RET, and all these mutation analysis for that. Whereas in situations where this is not possible, whether tissue diagnosis is not possible, or we only end up having a biopsy done from the bone, in those situations, a liquid biopsy is actually helpful. The liquid biopsy is also used for diagnosis and treatment selection because if a liquid biopsy identifies a mutation, more often than not, it is a true positive. And we can start treatment based on the mutation report. But in certain scenarios, if the liquid biopsy is negative, this is seen in around 20 to 25% of the scenarios. If the liquid biopsy is negative, make sure that you get a biopsy, however difficult it is, because you end up having mutation in one fourth of these patients. Liquid biopsy is also used for monitoring disease response. The TracerX data is a testament in this situation where it helps us identifying the risk of recurrence post-surgery or post-chemoradiation. It also helps us understand how the disease progresses on various systemic treatments and how the disease evolves with time. So it also helps us in identifying tumor heterogeneity. Certain mutations which are not founder mutations, which evolve during the course of treatment, might also have tumor heterogeneity, where the biopsy which is done from one side of the tumor might not identify, might not express these mutations, can be identified on a liquid biopsy. So these are the various advantages of liquid biopsy. The bottom line here is liquid biopsy or ctDNA testing may never replace tissue biopsy entirely, but it definitely has its place in regular day in to day in day out practice. The TracerX data, it's a really interesting data which was done by the UK group, where it tried to identify on how the tumors evolve. This is also one of the established technology for identifying MRD, though not done on a regular, cannot be done in a day in day out practice, but at least on a research setting. The TracerX used Illumina sequencing at a very high depths to identify that the tumor has not, there is no residual tumor that is that we regularly use in CML for BCR-ABL quantification. It tried to standardize that, but it is nowhere close. But it, at least in this data where it was seen that patients who were MRD positive ended up having more recurrences post-surgery than in group of patients who were MRD negative. So comparison of tissue versus liquid, we've all seen this comparison, but the points that I would like to emphasize is though liquid has several advantages, lesser invasive and rapid earlier reports, and more mutations that were detected based on the Nile study. There were more mutations when complementary liquid biopsy was used in addition to tissue biopsy. The points that I would like to emphasize here is analytical standardization. So the liquid biopsy, it's not the standard, the QCs that we usually run for liquid biopsies are not standard. The other thing is liquid biopsies tend to identify little lesser fusion abnormalities. Identifying fusion abnormalities on liquid biopsies is a little more challenging. RNA sequencing is a little more challenging on liquid biopsies than solid biopsies. So now individual mutations, I'll quickly try to cover these in view of time constraints. So EGFR mutation, the ideal methodology for EGFR mutation is either PCR or NGS, but NGS because of greater depth of sequencing. What is an ideal sample? An ideal sample is either a FFPE-based sample. Cell blocks are preferred over smears. Now, in early lung space, there is active data with the ADAURA data saying that there is an overall survival advantage with the use of osimertinib. At least a PCR for EGFR in a post-resected specimen is ideal. Now, we have a recent data leaks that have happened from ESMO, wherein even alectinib has shown significant DFS advantage when used for 2 years in the adjuvant space. So ideally, now I think there is actual data, there is active data happening even in the red space for adjuvant selpercatinib. We are actively awaiting for this data, but I think even in the adjuvant space now, where tissue would not be an issue in this space, I think waste time at the time where patients relapse. I strongly recommend that we all do NGS in the adjuvant space also, because now you have a very good tissue. Most of these mutations are founder mutations. So we end up identifying these mutations now, which will also have therapeutic implications like EGFR, ALK, and probably RET in the future. And also at a later point of time, the patients relapse, we can initiate the treatment without any delay in practice. Why do we need NGS over PCRs? This is very important for exon 20 insertions. There are a lot of exon 20 insertions that can happen, and nearly 48.6 as per one study identified more exon 20 insertions in NGS over PCRs, because normal PCR, whenever you order for a PCR and then you check on what are the probes that they identify, you see probably around 8 to 10 for exon 20 insertions that the PCRs cover. Whereas when you run an NGS, an exon-specific NGS, you identify more of these mutations. Some mutations like the short chain mutations like exon 763, 764 insertion deletions that happen in this space are even sensitive to the first generation TKS. So it's always better to run an NGS in the specimen for exon 20 insertions. ALK, a routine practice. Most often we do IHCs because the turnaround time is probably 24 to 48 hours. You can initiate the treatment earlier. It has very high sensitivity. But once there is a discordance on ALK on FISH versus IHC, the Indian data says that it is equivalent. They do benefit with these molecules, ALK inhibitors, but FISH positive and ALK positive patients do much better than patients having discordant results. Whenever you're running an ALK on a NGS report, please make sure your lab is doing RNA sequencing, because DNA sequencing can miss some fusion partners if a DNA NGS is run. ROS, again, the ideal method is always FISH. But if it is IHC positive, please make sure you run a FISH for establishing the diagnosis, and only then initiate these patients on treatment, because false positives on IHCs do happen with ROS. Whenever you're doing a sequencing on NGS, please make sure you're using an RNA sequencing. Now, KRAS, though it was for a very long time, was thought to be a non-druggable mutation. There is a specific KRAS G12C mutation where sotorasib and adagrasib have received fast-track approvals, though are not available in India. But again, DNA sequencing can be enough for these mutations. BRAF is a downstream mutation that happens. There are 1 to 5% of patients in lung cancer end up having BRAF mutations, but these are predominantly seen in smokers. Both KRAS and BRAF positive lung cancers are the only subset of mutation positive lung cancers which derive benefit with immunotherapy. Most other mutations like ALK, ROS, EGFR, RET, MET might not derive benefit with immunotherapy in this space. Again, MET, like I told you initially, normally splicing happens in introns, whereas in MET, there is splice variants that result from 13 to 15 fusion with exon 14 missing. So an RNA sequencing may be much better than a DNA sequencing. A selective MET exon 14 enrichment happens in the sarcomatoid cancers or the pleomorphic lung cancers. In these group, the sarcomatoid variants, there is an enrichment for MET mutations, MET exon 14 splice variants that we see. So RNA sequencing would be better. Like RET, there are 2 US FDA approved therapies, selpercatinib and pralsetinib. Again, mutations are more common in thyroid, and fusion abnormalities are the commonest in lung cancer. The commonest fusion abnormality is the KIF5B RET fusion that we see in practice. Selpercatinib is available on a compassionate access program, and whenever you're asking for a RET abnormality detection, it is always better to run an RNA sequencing. NTRK, again, there are a lot of molecules in the NTRK space. Entrectinib is again available on compassionate access program for NTRK. Larotrectinib and entrectinib are available. And again, NGS would be an ideal method and RNA sequencing would be an ideal method. So HER2 mutation, the most common location where HER2 mutations happen is the exon 20 in-frame insertions and deletions that happen. These have worse overall survival and very few targeted therapies available. There is data for afatinib in this space, trastuzumab, emtansine, TDM1 is also used, but the best results in this space are from the use of trastuzumab deruxtecan. So this is the flow chart for various therapies that we have in the space, and this is ever evolving. PD-L1 overexpression, we either use the 22C3 and SP263 platforms. Again, PD-L1, it is important that there is a significant concordance to the tune of 80 to 85% when either platforms are used. So in conclusion, biomarker testing has evolved towards a multiplex testing rather than single testing because of tissue usage and also better results that we see with deeper sequencings that we use. Adequate tumor content is required. At least a 10% viable tumor should be present in the blocks that we submit. An ideal turnaround time is around 2 weeks, and using a high throughput platforms like NGS, predominantly a DNA and RNA based NGS platform would identify most of these mutations. Thank you.
Thank you, Dr. Deepak, for this wonderful presentation. So we have few questions. So
Yeah.
one question I have in question answer, in the chat. So the question is, in liquid biopsy, is ctDNA and circulating tumor cell different? And what is the potential of each for mutation detection? So someone want to ask about the ctDNA versus CTC.
Yeah, so ctDNA is what we regularly employ for mutation analysis. CTCs, again, even on CTCs, we can culture CTCs and then extract DNA from CTCs and then run an NGS on that. We currently CTCs are predominantly used for there are platforms that are using CTCs for MRD analysis to prognosticate patients. We are currently not using CTCs for therapeutic decisions as such and for mutation analysis. But again, CTCs and ctDNAs can be used for sequencing and we can initiate treatments, but the turnaround time for doing sequencing on a CTC would significantly increase than using ctDNA.
Okay, so I also have few questions. They are basically of practical importance. Like, many medical oncologists are also sending and doing NGS on the tissue and also at the same time on, the liquid biopsy. So what is your take? Like, is there a benefit of sending NGS and both of the samples, or we need to select some patient where we need to send tissue and after that liquid biopsy?
Very good question, Vikas. So the IACLC guidelines recommend using complementary testing. So it recommends that we use both liquid and solid biopsies. And this is based on the Nile data. This is published by Natasha Lay group. It is a community-based study that was done in Canada. And they've seen that around 15 to 20% patients, they end up identifying more mutations by using liquid biopsy in addition to a solid biopsy. Now, there are certain limitations of the study per se. It was a community-based setup, and there were EGFR was predominantly run by PCRs, and NGS was used on the liquid biopsy. But all this apart, we have certain issues getting tissues also, and the quality and the tumor content in the biopsy specimen might not be adequate, and sometimes the lab might not give us that. So in that situation, in practice where patients are affordable, we are doing liquid biopsy and also tissue biopsy. The other advantage by using this method is the turnaround time for liquid biopsy is somewhere around 5 to 7 days. So you end up identifying mutations, initiating these patients on treatment a little early than on tissue biopsy. But again, if the liquid biopsy is negative, please do a tissue biopsy and make sure you're running an NGS on that, because 1/4 of these patients end up having mutations on the tissue biopsy. Most often these are fusion abnormalities.
So what I am understanding that tissue NGS is even more important than doing NGS on liquid sample.
Liquid samples, but liquid samples can end up identifying more mutations. The turnaround time is lesser. So yeah,
In the
10
follow-up questions like the limited panel versus doing full NGS, we have coupons, we are utilizing them.
Yeah.
So where we have, the 9 gene or 11 gene or 18 gene. And when we compare to the full NGS where we are, testing for 300 odd genes, what is your take? It is really beneficial to go for full gene NGS? And do we have any selective parameter for doing full NGS rather than the limited panel?
These are personal views, and I might
Yeah, I
a lot, but on my personal take is identify what you can target, because prognostication is just going to create more apprehension in the patient's family.
correct.
Tumor mutation burden probably can be an answer for doing more NGS by doing an whole exome sequencing or a extended panel sequencing. But the problem with that is tumor mutation burden consistently has failed, at least in the lung cancer space. So in my practice, a limited sequencing NGS done with a good quality controls, done with a good depth, and then moving ahead would be more practically relevant for patients, spending lesser money and getting better results. That's my take on that, using extended panels.
Okay, so is there any
Dr.
more
Deepak,
question?
while sending for NGS, will you specify that this gene should be done by RNA and sequencing, or this should be done by DNA sequencing, or your lab is only deciding?
So the labs that I usually send, I've had experience. I've spoken to the molecular biologists at these labs, and they are very clear that fusions, they insist on getting an RNA sequencing. There are some labs which only do DNA sequencing even for fusion abnormalities. And whenever these executives come and they offer us a brochure, as medical oncologists, we should at least ask or search for this, that how are these fusions being run.
Okay.
So I think,
today only I realized those things. So I just want to know whether this with MedGenome coupon we are doing with AstraZeneca, whether they are doing with fusion both modality, or they are doing with single modality.
I'm not sure. I've not really seen.
So I think they are doing DNA and RNA both, because we are having mutation of something like ALK, which is very difficult, like cannot be detected by DNA. So I personally discussed this maybe a year ago with the MedGenome people, and they are doing both DNA and RNA.
I think,
and they are reporting both separately.
Okay.
Yeah. I think most standard labs are doing RNA sequencing because molecular biologists know that they need to identify those mutations, and the way for them is RNA sequencing. DNA sequencing can identify these mutations, but your probes can identify the commoner ones. They tend to miss the rare fusion abnormalities. So that's the reason an RNA sequencing would be better. Yeah.
Okay.
Okay. Thank you, Dr. Deepak.
Thank you.
Now we will move to the next session. And the next session will be taken up by me, and it is about stage 3 NSCLC. So can someone allow me to share my screen, please? Or I think someone has to stop sharing, then I will be able to share. Okay, thank you. Yeah. So good evening, everyone. So I will be discussing about the management of stage 3 NSCLC. So let's start with a simple case. So we have a 52-year male who presented to us with the complaint of weight loss and dry cough. So this is the common presentation lung cancer patient usually come. There is no comorbidities, and as a regular, the physician will ask for the chest X-ray. In the chest X-ray, there is evidence of radio-opacity in the left upper and middle lobe, and there is also some perilesional haziness is present. There is mild bilateral apical thickening also seen. So once there is something abnormal on the chest X-ray, definitely the first next imaging modality will be a CCT chest. And in CCT chest in this patient, there is a large heterogeneous lesion with necrotic component involving apico-posterior segment of the left upper lobe, suggestive of some neoplastic etiology. In addition, there are also some enlargement of mediastinal lymph nodes, and there are also a small nodule seen along the right lower lobe that may represent either an infection or metastatic lesion. So because we know that the characterization of this nodule is important, because with this the stage will change, and when on CT scan there is some confusion, the best modality can be the PET scan. So PET scan was performed, and in the PET scan, we can see there is metabolically active soft tissue density of around 7 into 7 into 8 centimeter in the left left upper lobe, and also there is contralateral mediastinal lymph node also involves. So here it will make it T4 because there is abetting of posterior mediastinal pleura, and because the contralateral lymph nodes are involved, it will become N3. So T4, N3. There is no distant metastasis. The stage will become stage 3C. Then the CT guided biopsy of the lesion was done. So it is poorly differentiated. So as this is a typical thing that I teach to my students. So whenever it is written like poorly differentiated, don't read after that. So it is poorly differentiated where a carcinoma, tumor, and so on. Please do ISC. On ISC, TTF1 is classically positive, suggestive of lung primary lesion, and the biomarker testing NGS was negative, PDL 1%, 20%. So diagnosis was adenocarcinoma left lung, clinically T4, N3, M0, that is stage 3C. So the important question that comes to our mind, what is the intent of treatment for this case? So as we know, this is the locally advanced disease, not non-metastatic. So definitely our intent of treatment will be radical. How successful we will be, that we will discuss in the subsequent slide. But again, as of today, at least for this patient, the treatment should be radical, and how we are going to achieve it. So the best way to treat such type of patients is to do the MDT, involve the different people of different branches, radiation and medical oncologist, surgeon, and so on, because we have enough data to prove that the patients who are treated in the MDT has a better survival, because with the discussion, with the help knowledge from each other, the better decision can be made, and we can provide the optimal treatment. So what should be the logical next step for this patient in your practice, T4 and N3? So there can be three scenarios. One is the consult a thoracic surgeon and plan for surgery. The second can be neoadjuvant CTRT followed by restaging, whether our patient has become can be operated or no. And third is definitive concurrent CTRT. So as we note that when the contralateral lymph nodes are involved, N3 lymph nodes are involved, patient is not a surgical candidate. And for such type of patient, definitive CTRT is the answer. Now coming to the one of the controversial issues, the induction chemotherapy. So we may not have a big data for induction chemotherapy, but again we know that our patient can not be an ideal candidate for going upfront CTRT due to varied reason, either patient related or tumor related. Sometimes the primary is so large, sometimes patient is not fit, patient is having comorbidity, sometimes the patient has poor PS. So for this, we cannot subject the patient for upfront chemoradiation, and all these patients we give induction chemotherapy. This patient also received 3 cycles of paclitaxel plus carboplatin, and post 3 cycles of chemotherapy, the PET scan shows partial response. So the question is, do we have any data for induction chemotherapy, or it is just the individual decision? So if we see the data from the Pacific trial, 1 out of 4, around 25% patients do receive induction chemotherapy. So when we give induction chemotherapy, like we should be aware that yes, I cannot recommend all patient concurrent chemoradiation on day 1. So after induction chemotherapy, now patient is planned for chemoradiation, and the chemotherapy used here is this can vary, but I think the most common regimen that people use is weekly paclitaxel, weekly pacli-carbo. But the only apprehension that I has in this patient using this regimen, that patient already received the 3 doses of carboplatin, and now patient will again receive 4 or 5 or sometimes maybe the 6 doses of carboplatin. High chance that patient may develop carboplatin reaction hypersensitivity in the 6th or 7th dose. So that we need to be careful. Now the radiation dose is around 66 grade, that we will also discuss in the subsequent slides. Patient tolerate treatment well. So coming to the sequential versus concurrent, again we have enough evidence phase 3 trial with concurrent chemoradiation is better than sequential chemoradiation. But again, in a well-fit patient, we need to choose our patient very carefully. Concurrent chemoradiation may not be feasible in all patients, but definitely where possible, concurrent chemoradiation scores over sequential chemoradiation. So as we note that the stage 3 lung cancer, which is a heterogeneous group of diseases where you have limited nodal station, where surgery is feasible. Surgery followed by adjuvant chemotherapy has given the best best outcome. But in the patients where surgery is not feasible, the best outcome after the surgery and adjuvant chemotherapy is the patients who receive concurrent chemoradiation. So this is the message that if given a choice, concurrent CTRT should be the way to go. 4 weeks later, start on steroid because patient develop radiation pneumonitis. It is not uncommon that our patient do develop radiation pneumonitis. That is in the later, later weeks of the treatment, and sometime even after completion of treatments. So the treatment, the patient received low dose of steroid, and now the radiation pneumonitis resolves. So then question, what should we do after CTRT? And here the importance of immunotherapy comes into the pictures. So I will not go into the details, but again, we have enough data that there is no role of consolidation chemotherapy. And also there is not much difference between, the 60 gray versus 74 gray of radiation. So no consolidation post CTRT. So how to consolidate patients? So I think the best data is with durvalumab based on the PACIFIC trial. In this trial, the patient with stage 3 locally advanced or unresectable NSCLC who have not progressed following CTRT, they were randomized within 6 weeks of CTRT to durvalumab versus placebo. The dose of durvalumab was 10 milligram per kg every 2 weekly, and treatment was given up to 1 year. The primary, there were co-primary endpoint, the PFS and the OS.
Sorry to
Yeah.
तो आप अगर वीडियो it will be clear.
हाँ?
आपका नेटवर्क से इशू आ रहा है सर, आपकी आवाज कट रही है बीच में.
How is it now?
अभी सही है सर.
Is that okay?
Yes, okay, it's okay.
Okay. So this is the data from the PACIFIC trial. All patients received 2 or more overlapping cycles of platinum-based chemotherapy concurrent with RT. And you can see that this, we have already discussed that 1 out of 4 patients received induction chemotherapy. So this is the patient characteristic, and the important thing that patient with EGFR positive patients was also included in this trial. This is coming to the forest plot for PFS. We can see that most of the subgroup benefited with consolidation durvalumab. And the one thing that surprises me that the hazard ratio for non-squamous histology was better than the squamous. I really don't know. Maybe Dr. Deepak can take this question after my presentation. That what can be the reason that the hazard ratio for non-squamous histology is better than the squamous? And also we can see that the PDL score really doesn't matter whether it's low or high. Everyone benefited with durvalumab. This is the only and first approved immunotherapy to demonstrate not only the PFS but OS benefit. Now the patient is planned for durvalumab, daycare admission for durvalumab, and the question is, when is your time for assessment post CTRT? So I think as soon as the side effect of CTRT completes, resolves, maybe around 6 weeks or a week or even prior, we can assess whether my patient is responding or not. So if their patient is responding, he or she will be the ideal patient for durvalumab. And best time, as soon as the side effect vanishes, we can start. So this is during the durvalumab, you can see there is the response is ongoing, and this is maybe at the end of 1 year, week 51 of immunotherapy, almost complete response to durvalumab. So if we see that traditional OS with concurrent chemoradiation, the 5-year survival is hardly 15 to 25%. But if we consolidate based on the PACIFIC data with durvalumab, there is not only an increase in PFS, but there are also increase in OS. Coming to the guidelines, if we see the Indian guidelines, NCCN and ESMO, I think in all the 3 guidelines, anonymously that it is category 1A recommendation. The only difference between NCCN and ESMO is that in ESMO, the durvalumab is category 1A if the PDL1 is more than 1%. Otherwise, you can see that either you take Indian or international guideline, durvalumab is category 1 indications. So The take-home message that MDT approach give the best outcome for stage 3 NSCLC. Concurrent chemoradiation is better than RT or CT alone. Consolidating chemotherapy do not improve the outcome. First and only approved immunotherapy to demonstrate OS and PFS benefit. Durvalumab should be considered a treatment option in all unresectable stage 3 patients who has not progressed following CT-RT. And Durvalumab improve outcome all subgroup irrespective of PDL1. I may not be agree with EGFR status. So Durvalumab is a new standard of care in a stage 3 unresectable NSCLC post CT-RT. Thank you so much. So if any question, I will be happy to answer. Otherwise, we will move to the next session.
Sir, question is raising through Q&A, sir.
Okay. Why not perioperative chemoimmunotherapy? Perioperative chemoimmunotherapy, yes, that can also be tried. But again, perioperative immunotherapy, we have to be very careful that N3 patients, when you have N3 patients, that will not go, in the OT, never. So in such patient, I will not try for perioperative chemotherapy. I will select my patients. So if I think that after giving operative chemotherapy, we can downstage the disease and patient can become operable, then only I will try. Otherwise, in N3 patient, at least the patient that I have presented, I will not go for perioperative.
I think we don't give neoadjuvant chemotherapy to inoperable patients. We don't have phase 3 trial that to make inoperable to operable. We can consider case by case basis. Otherwise, we don't give neoadjuvant chemotherapy to make inoperable as a operable. And if N3 disease or N2 bulky disease, we can upfront only we deem them at inoperable.
Yes. Okay. So now we will move to the next session. And for the next session, we have Dr. Akash Tiwari. And Dr. Akash is, one of the prominent medical oncologists of the city of Indore. He is working at Selvi Hospital, and he will be discussing about the EGFR therapy, the role of osimertinib and the present indication. Over to Dr. Akash.
Thank you, sir. Can someone share my slide, please? So the study, what we will be discussing is improving outcomes in EGFR mutated non-small cell lung cancer, and we'd go beyond the usual EGFR TKIs. Change slide, please. So what has happened over a period of time is that just use of EGFR TKI gives a plateau of response, and hence there is a rationale of combining it with other agents. We have trial of TKI plus chemotherapy, TKI with VEGF inhibitors, and TKI with EGFR antibody trials. Change the slide, please. And over a period of time, these drugs have shown improvement, these combinations, and that's something that we'll see subsequently. So non-small cell lung cancer, we know, has evolved as a disease. In our lifetimes, we treated all them as small cell versus non-small cell. Then the histology-based treatment when the pemetrexed versus gemcitabine data came, and subsequently to the molecular behavior of the drugs, where we study the different driver mutations and we are able to target these. Change, please. So what happens is that there were initially, when we started with testing, as we discussed earlier, it was a sequential testing with EGFR, ALK, ROS by different mechanisms. So we used to send PCRs there, FISH for ALK and ROS. From there, what we have moved on to is to a simultaneous testing via NGS. It gives us a greater depth as well as better utilization of the tissue. Change the slides, please. So metastatic adenocarcinoma, how the biomarker testing consensus today is that we must test them simultaneously. And if there is a driver mutation, we treat based on the driver mutation. Otherwise, we treat based on the current standard recommendations. And we give chemotherapy before availability of this disease only if the patient is sick and cannot wait for the reports. Change slide, please. Hello. Change slide, please. Ankit.
Ankit,
So biomarker testing at progression, nation consensus uniformly says that irrespective of if the patient were previous EGFR mutated, treated with targeted medicine, not treated with targeted medicine, if a baseline mutation was present or not, one must check an NGS panel by ctDNA or a newly acquired tissue, because sometimes we may acquire new mutations that may be targetable. And this is something which has been our experience too in this field. Change the slide, please. So over a period of time, what has happened is that the survival of CA lung has changed significantly. From the times of 4 to 6 months of metastatic CA lung to the times where the ROS1 survival data is over 3, 4, 5 years is something phenomenal. And it has only happened because of addition of the targeted medicine. Amit, will you be able to change it, please? So, with the use of TKIs, we are able to reach a plateau in terms of how much response we are getting. And hence, these drugs have been combined with other agents. So we know this data of erlotinib with ramucirumab, EGFR with cytotoxic chemotherapy, something that erlotinib with cytotoxic chemotherapy, something that we have been using regularly, and that with EGFR antibodies. Change the slide, please. So the rationale of combining these TKIs with chemotherapy is essentially that the drug, the oral TKI, it decreases thymidylate synthetase and therefore enhances the pemetrexed efficacy. On the other hand, the chemotherapy drug addition reduces resistance by suppressing the AKT pathway and the extracellular signaling regulated kinase phosphorylation. And hence, change the slide, please. And hence, as we had seen in the trials that we had done earlier from the TMH study, as well as the other data, that addition of chemotherapy to TKIs have provided better results. So in TMH study, we essentially took advanced NSCLC, which were EGFR mutated, randomized them between gefitinib plus chemotherapy, the standard chemotherapy, continued with maintenance plus gefitinib, and gefitinib alone. The primary endpoint was PFS. Change the slide, please. So the results that we have was phenomenal. So we have a PFS with hazards of 0.51. So almost a 49% relative risk reduction of progression or death, with a relative risk reduction mortality by almost 55%. And this was the change the slide, please. And this was probably the intervention that a lot of us have been using sometimes in want of the drug that we all want to use. So the exon, and you know that all patients, exon 19 mutations, age-wise, gender-wise, all subgroups responded. Though we feel that there's something else needed in these patients who had brain metastasis. Would you change the slide, please? So the other trial that is available is the NEJ 009. It is gefitinib alone versus gefitinib plus chemotherapy. It also included advanced NSCLC who were previously untreated, and they were randomized between gefitinib plus chemo versus gefitinib alone, with the primary endpoint being PFS. Change the slide, please. The what we have had then is essentially a significantly elevated progression-free survival as well as the updated OS, though not statistically significant, but there's trend towards the same. Could you change the slide, please? And the benefit was there uh, irrespective of other factors. But as we had seen earlier, these patients with brain metastasis, those with liver metastasis, those with brain metastasis were doing slightly poorer as compared to those with who had did not have brain mets. Change the slide, please. Change the slide, please. So change the slide, please. So then, apart from the first-line agents, there are other trials also that we have in terms of the platinum doublet plus the recurrent squamous or non-small cell lung cancer that are EGFR mutated. So it included patients. Click once, Ajit, again. There's a central part of this slide. So what we have is patients. They were randomized between either gefitinib or osimertinib. Or gefitinib or osimertinib plus chemotherapy combinations, and these combinations were then continued with maintenance. In terms of the interim analysis, we see that when gefitinib versus gefitinib was chemo was compared versus when osimertinib, the combination with osimertinib was compared, the hazard ratio was 1 and 0.83 respectively, and was not statistically significant. Could you change the slide, please? In terms of the secondary endpoint of PFS also, this comparison was not statistically significant. Change the slide, please. So the next study that we see is essentially the OPAL trial. In the OPAL trial, patients with untreated EGFR mutated non-small cell lung cancer were randomized between osimertinib plus chemo induction arm with maintenance with osimertinib and pemetrexed maintenance, compared with osimertinib with carboplatin plus pemetrexed, and osimertinib plus pem were continued. When we compare the 12-month, 24 months PFS and OS, could you change? Hello? So, so with this background, what we have is the data from the osimertinib. So what we have from this is the data from the FLORA-2 trial, which is actually the trial in question. So most patients with EGFR mutated lung cancer will progress with CNS metastasis, and this has been our experiences too. Osimertinib, we know that has CNS penetrance, and hence it is the preferred first-line therapy. There's clinical data of first-generation TKI combined with chemotherapy and its associated benefit that we had seen earlier. Osimertinib plus platinum plus chemo in the OPAL trial that we were seeing earlier had shown encouraging results. So this sets the background of the FLORA-2 trial. Could you change the slide, please? So in the FLORA-2 trial, we had patients who were untreated or advanced non-small cell lung cancer, could have had either actionable mutation and with no systemic prior therapy. These patients were randomized to receive either osimertinib alone or osimertinib plus chemotherapy. And these patients were then followed up. The primary endpoint was PFS and the secondary endpoint was OS, other endpoint parameters too. Could you change the slide, please? So we'll first look at this parameter. At the median, PFS was improved by almost 8.8 months when we used osimertinib plus chemo versus chemo alone. So we see that in the combination arm, the PFS was 25.5 months versus 16 months, which was statistically significant, and the hazards ratio was 0.62. And we see that the curves continued to be separated at 2 years duration also. Could you change the slide, please? When we see in the progression-free survival, as per as the BICR, we have a similar result. with a significantly improved progression-free survival, both at 12 months as well as 24-month duration. Change the slide, please. So as far as the subgroups are concerned, irrespective of the gender, race, what type of EGFR testing was there, what type of mutation was there, and if there was a CNS mutation present or not, these patients did pretty well. Could you change the slide, please? So in patients who had CNS metastasis versus without CNS metastasis, we see that in patients with CNS metastasis, a combination gave a progression-free survival of 24 months versus 13.8 months in osimertinib alone arm. Whereas in those without CNS metastasis, the difference was 27 versus 27.6 months versus 21 months. So we see that though both of them benefit, the benefit seems to be more exaggerated in those with CNS metastasis arm. Could you change the slide, please? In terms of the exon, what type of deletion is present? We see that though we know that L858R subgroups do poorly as compared to exon 19 deletion, it seems as if addition of chemo to the osimertinib is actually bridging the gap between the two mutations. Could you change the slide, please? And the combination benefits all. So the common mutations or the common toxicities remains the same. It is the addition of the hematological toxicity that makes this combination look bad. But it has been our experience with platinum plus pemetrexed that these patients otherwise do well, and most of our patients tolerated the combination well. Could you change the slide, please? So the second combination that we have is a TKI plus VEGF inhibitor. So we know that there's a crosstalk between the EGFR signaling and the VEGF signaling, and there are drugs that can that inhibit VEGF like ramucirumab and bevacizumab, and hence there has been a combination that has been studied. Could you change the slide, please? So we know that there have been several trials that have actually been used where there is a combination of a first generation TKI with an anti-VEGF inhibitor. And we see that especially in the combination of a first generation TKI with ramucirumab, the results were better in the combination between the two in terms of the progression-free survival. Bevacizumab at the end, for unknown reason, could not show a similar benefit. You change the slide, please. So the summary of NEJ 026, C2ONG 1509 and Relay essentially shows that addition of erlotinib with bevacizumab gives an overall response rate of 72 versus 76%. In the ramucirumab plus erlotinib arm, erlotinib plus bev arm, the responses are almost comparable in the combination arm. In terms of the median PFS hazards ratio, so we'll consider the intention to treat. So the hazards ratio was 0.6, 0.05, and 0.59. So these are almost a 45% relative risk reduction in terms of PFS, and we know that there is no OS benefit with this combination. Could you change the slide, please? Please increase the checks. So we know that the other combinations that we have seen is actually a combination of first generation TKI with an EGFR antibody. So it is lazertinib as well as the amivantamab combination has been studied in this subgroup. The drug lazertinib is highly selective. It penetrates brain. It is a third generation EGFR TKI, and it acts on both T790 mutation and has CNS penetrance. Preclinical studies show that the anti-tumor activity improves when both extracellular and catalytic EGFR domains are simultaneously targeted with the combination when the drug is combined with the amivantamab. The overall response to patients who are progressed on osimertinib with this combination was almost 36%, with a duration of response to 9.6%, which looks as a very impressive result. Could you change the slide? And something that is visible in the waterfall curves also. There's one more part of the slide. Please move on. So, amivantamab plus lazertinib yields a dual anti-tumor activity in patients with EGFR mutated non-small cell lung cancer. There is a consistent, the safety of this drug is proven and there is no significant safety signal. Could you change the slide, please? There's an ongoing trial which addresses amivantamab plus lazertinib as a first-line therapy versus comparing this with chemotherapy, which have followed on the progression of osimertinib. And the data of it is awaited. Could you change the slide, please? So summarizing, newer TKI plus chemotherapy in first line is an option that should be given to patients. That TKI with combination of other agents are promising, but we usually don't use these combinations with availability of better combinations. The vital thing is to choose the right patients who can tolerate the combination and the toxicity. Thank you. Change the slide, please.
Thank you, Dr. Akash. So I have one question, like, if given a fit patients with brain mets, are you ready with the data of FLAURA2 chemo plus osimertinib?
Yes, sir.
Still you
Yes,
want
sir.
to get OS data?
No, sir. I feel that with the data that we see, I am convinced to use the combination. I feel that with our experiences with the first generation TKI and chemo, we know that the patients tolerate chemotherapy well, most of them. And the addition of an EGFR TKI does not add to significant toxicity. So even with a good PFS data and in absence of OS data also, I'll be happy to use the combination.
Okay, thank you. Let's move to the next presentation. And next presentation is by Dr. Rajesh Patidar. He is a consultant medical oncologist, associate professor at SIMS Medical College. And he will be discussing about why osimertinib in advanced EGFR positive NSCLC. Over to Dr. Rajesh.
Thank you. My slides are visible?
Yes, yes.
Yes, sir.
Yes, okay. So I think Dr. Akash has elaborately presented how we treat now EGFR mutated lung cancer, and I'll be discussing only osimertinib, and he has discussed one step further, osimertinib with chemotherapy, the latest trial. And we all know that osimertinib is a standard of care in EGFR mutated non-small cell lung cancer. Slides. Okay. So if we see the FLAURA trial, which was a phase 3 first phase 3 randomized trial by which the osimertinib became the standard of care in advanced non-small cell lung cancer with EGFR mutation positive diseases. The progression-free survival was 18.9 months in this study. If we compare with the standard EGFR TKI, in which it was 10.2 months, with hazard ratio of 0.46, with statistically significant p-value, with median overall survival was 38.6 months compared to 13.8 months, with hazard ratio of 0.799. And if we see the Kaplan-Meier curve, both the curves from the very beginning, they were separated, and they were separated till the end. So why osimertinib in first line EGFR mutation non-small cell lung cancer? Since we know that osimertinib is a third generation TKI, erlotinib and gefitinib, they are the first generation TKI. Afatinib is a second generation TKI, and decomatinib is second generation TKI. So we know that initial trials compared TKI with chemotherapy, and if we see the gefitinib, in gefitinib they compared in IPASS trial, first signal trial, NEGSGS 002 trial, and WGTOG 3405 trial. In all this trial, the median PFS ranges from 9 months to 11 months, and in chemotherapy arm, the PFS was around 6 months. And if you see the erlotinib, the trials are Optimal, Eurotech, and Torch trial. And in this trial also, the median PFS ranges from 9 to 13 months. In erlotinib and in chemotherapy, it was 5 months to 6 months. And if you see the afatinib versus chemotherapy, it was 13.6 versus 6.9. And in lung 6, it was 11 versus 5.6 months. And in decomatinib study, Archer 1050 trial, it was 14.7 months versus 9.2 months. So the majority of patients treated with EGFR TKI ultimately progress with an average PFS of 8 to 14 months. And if you compare with the FLORA trial, in that trial, the median PFS was 18 months. So if we see the various trials which have compared head-to-head TKI in advanced EGFR non-small cell lung cancer, if we see CTONG 0901 phase 3 trial, which was in TKI naive patient, they compared erlotinib versus gefitinib. And if we see WJOG 5108 trial, it was also TKI naive previously treated patients, in which in both of these trials, the PFS was around 10 months in erlotinib and 13 months in erlotinib and 10 months in gefitinib. Similarly, Lux Lung 7, they compared afatinib with gefitinib, and the median PFS was 11 months in afatinib and 10.9 months in gefitinib. And if we see the decomatinib versus gefitinib trial, the median PFS was 14.7 months versus 9.2 months. And if we see the FLORA phase 3 trial, the median PFS was 18.9 months versus 10.2 months. So osimertinib fared well compared to all TKI, first and second generation TKI. Maximum PFS what we see in osimertinib is 18.9 months, and second best TKI was decomatinib, in which it was 14.7 months. So almost 4 months, if we do the cross trial comparison, almost 4 months better PFS in osimertinib compared to decomatinib. These are the studies with the various TKI. First is, if we see the afatinib, they compared in Lux Lung 3 with chemotherapy, and the overall response rate was 56 versus 23 months with median PFS of 11.1 versus 6.9, and OS was similar in both the group because crossover was allowed in most of the studies. Lux Lung 6, if we see, the overall response rate was 66.9 months versus 23 months with 11 month PFS versus 5.6 month. And if you see the median OS, it was 23.1 versus 23.5 months. Similarly, if you see the decomatinib study, in Archer study 1050 arm, they compared decomatinib with gefitinib. The response rate was quite similar, 75 versus 72 months. And median PFS was 14.7 months versus 9.2 months. And median overall survival was 94.1 month versus 26.1 month. So osimertinib showed better PFS as well as OS in EGFR mutated advanced non-small cell lung cancer if we compare with other TKIs. So let's see the NCCN guidelines in EGFR exon 19 deletion or L858R mutation patients. NCCN recommends a category 1 recommendation for osimertinib, and other recommendations are erlotinib, afatinib, gefitinib, decomatinib, and we know that these are all inferior recommendation compared to osimertinib. And if patient has been started with chemotherapy, then we can interrupt the chemotherapy or we can continue, and once disease progress, we start targeted therapy. But in our practice, we usually interrupt the chemotherapy and we start osimertinib. And now, as Dr. Akash has presented that we can give chemotherapy with osimertinib, then I think we can continue osimertinib and we can continue chemotherapy and add osimertinib in that. If we see the ESCO guidelines also, they recommend the osimertinib as a monotherapy in EGFR mutation sensitive patients, and other recommendation also they give other TKI or sometime erlotinib with bevacizumab or monotherapy with erlotinib or monotherapy with gefitinib. They are moderate recommendation. The strong recommendation is osimertinib monotherapy. If you see the ESMO guidelines 2023, in this again, osimertinib is the first recommendation and is the preferred recommendation in advanced non-small cell lung cancer with targetable mutations. So why these are all the we have discussed these phase 3 trials. Does this drug work in real world setting also? So answer is yes. We have now various studies like Flower, OCFECT and MYKONOS studies. In this, all these studies, the progression-free survival in real world also ranged from 16 months to 20 months. And the adverse grade 3, grade 4 events are less. And we know that this is the least toxic TKI. And this is most sensitive and most specific to the mutated EGFR receptors, and this does not act on wild EGFR receptors. So this is the most sensitive, most specific TKI and most potent TKI, and this is the least toxic TKI. So main problem with these targetable mutations are that these patients are commonly present with the brain metastasis, and this is the drug which has highest blood-brain barrier penetration compared to other first and second generation TKI like erlotinib, gefitinib. And this picture is showing, this is a picture of monkey, and monkey's brain. We are able to see that osimertinib is the drug which has penetrated the most even in the brain. So it has a better brain penetration compared to other TKI in the preclinical studies. And this is a human brain, and in human brain also, the osimertinib was labeled with Carbol level, and then they found that this TKI has highest blood-brain barrier penetration inside the human beings. So if we see the flora, and we do subgroup analysis of CNS metastasis versus whole flora. In flora CNS analysis, there was 128 patients, and male to female ratio in osimertinib was 38 patients were male and 62% were female, and in EGFR TKI comparator arm it was 40 versus 60. Median age was 63 years in both the arm. White patients were 30 to 40% in the both the arm. But most common patients were Asians. WHO performance status was most of the patients were 0 to 1, and most of the patients had exon 11 mutation compared to ALAT5 beta mutation was seen in 30 to 35% of the patients, and almost all patients were having adenocarcinoma. CNS lesions 1 to 3 was seen in 77 patients, and more than 3 lesions were seen in 23 patients. And prior brain radiotherapy was given in 25 patients in the osimertinib arm and 24 patients in the EGFR TKI comparator arm. So if we see the PFS, the median progression-free survival was 15.2 months versus 19.6 months. It was almost similar to what we see in a Flora complete study. So this drug acts even patients has brain metastasis, and the PFS is almost similar to those patients who do not have brain metastasis. So CNS disease progression was mostly driven by new CNS lesions on osimertinib. Fewer patients experienced CNS progression, and fewer patients progressed due to new CNS lesion with osimertinib treatment compared with EGFR TKI comparator. So median best percentage change from the baseline in CNS target lesion in osimertinib, it was 64%, and in EGFR TKI comparator arm, it was 45%. So overall response was also better in osimertinib arm compared to EGFR TKI arm. Majority of patients on osimertinib had a partial response along with complete response in a few patients, and it was not so in EGFR TKI arm. So it doesn't only improve the PFS, OS, but it also improves the quality of life. These are the key important indicators for a clinical trials. And if we see the global health status, physical functioning, role functioning, emotional functioning, cognitive functioning, and social functioning, in this all parameters where we assess the quality of life, osimertinib fared better compared to other EGFR TKI in a Flora study. If we see the symptoms also, the cough, dyspnea, chest pain, fatigue, and appetite loss, almost in all these symptoms, osimertinib relieved this symptom with better compared to gefitinib or erlotinib. And if you see the side effects, we know that the best drug in terms of side effects also, it is osimertinib. Osimertinib have rarely some side effects. Sometimes it could be diarrhea or stomatitis. And only in 4% of the patients in a FLORA trial, dose reduction was required. Afatinib, we know it is a toxic drug. The most common side effects are diarrhea, and dose limiting side effect of this afatinib are diarrhea and pyronychia. Rashes were also observed around 10% of the patients. Decomatinib, again, it is a difficult to tolerate drug. The rash or acne was observed in around 13.7% of the patients. Pyronychia was seen in 7.5% of the patients, and diarrhea was seen in 8.8% of the patient. Stomatitis was seen in 3.5% of the patient, and the most important thing, the dose reduction was required in around 2/3 of the patients required the dose reductions. So whether we shoot this TKI in a first line setting or second line setting, the answer is if patient is eligible, then we should use this drug in a first line setting, because many of these patients in whom we don't use them in a first line setting, we use other TKI like afatinib, gefitinib or erlotinib. Then in second line, we give only to those patients who harbor T790 mutations. So T790 mutations is present in around 1/3 to 2/3 of the patients. Not all patients harbor T790 mutations. And many of these patients who harbor these T790 mutations, their general condition may not permit to use osimertinib in a second line. Or the disease might progress in such organs where we might not be able to use these drugs again. So whenever possible, we should use osimertinib in a first line setting where we get around 18.9 month of PFS. And if we use the EGFR TKI, then weighted average PFS is only 15 months, and around 1/3 of the patient do not receive any therapy after progression on the first generation TKI. Now, again, we have various options like if we use decomatinib followed by osimertinib. In a decomatinib first line setting, the median PFS is 14.7 months. And if patient harbors T790 mutation, then if we use osimertinib, then the median PFS is 10.1 month with OS of 34.1 month. And if we use afatinib initially, then median PFS is 11 months. And if we use in a T790 mutant patient, then median PFS will be around 10.1 month. So overall survival is only 27.1 month, which is lesser. But what we see with osimertinib is a first line setting, which is around 34 to 36 months. So this again, if we compare gefitinib versus gefitinib with chemotherapy, the median PFS is 16 months versus 8 months, and grade 3 toxicities was observed in 51% of the patients. Other options were like remaruzumab with erlotinib. In that, PFS was 19.4 months, but grade 3 toxicities were 72%. And if we use erlotinib with bevacizumab versus erlotinib, the median PFS is 16.9 months without any improvement in OS benefit, and grade 3 toxicity is 88%. And if we use osimertinib alone, then median PFS is 18.9 months with OS at 38.6 months and very less grade 3 toxicity. It is around 34%. So combination increases PFS, but also increases the toxicity, and it needs more hospital visit and may decrease the compliance also. So to conclude, osimertinib upfront provides the possibility of OS benefit of 38.6 months to all patients with comparatively few adverse events. Only 7 out of 10 patients get tested for second line treated options, and 20 to 30% patients don't receive a second line treatment. T790 mutations positivity in second line is only around 40 to 50%. Osimertinib has shown better efficacy in a brain metastasis, as well as it delays the CNS progression. So it should be the first line treatment options in a patients who harbor EGFR mutated non-small cell lung carcinoma. Thank you.
Thank you, Dr. Rajesh. We are already running short of time, so I will move to the next session. And for the next session, we have Dr. Shyam Agrawal sir. He's a director at Navodaya Cancer Hospital, Bhopal. And I invite you, sir, for the topic, the evolving landscape of CDK4/6 inhibitor, the implication for clinical practice. And this session is sponsored by Novartis. Over to Shyam, sir.
Yeah, good evening, Vikas. Am I audible?
Yes, yes, very much audible, sir.
Okay. Thank you very much for having such a nice update on so many uh, aspects, especially, lung and GI and breast is really, and for my topic is CDK4 inhibitor landscape, which is rapidly evolving. And now the topic is like we as know the ribociclib is coming up in a great way, but palbo is becoming cheaper. But we have to see which one is better. So this is the whole presentation is on how to start out which one is the best. So next, please. Next. So when we considering an option of advanced breast cancer, ER/PR positive or HER2 negative, which is our goal of primary treatment, whether it is overall survival or PFS. That is what we are going to discuss in subsequent 30 minutes or 25 minutes or so. So the majority of oncologists and women have surveyed, and they reported that overall survival is the number one treatment goal for any treatment which we opt for. Next, please. And the US FDA also has done clinical trials endpoint for the approval of cancer drugs and biologics. They've defined as time for randomization until death from any cause and is measured in the intent to treat population. In those situations, overall survival is considered the most reliable cancer endpoint. And when the studies can be conducted to adequately assess survival, it is usually the preferred endpoint. Next, please. So, are all the CDK4 inhibitors, they are all game changers, or there is some difference in the management of HER positive negative hormone receptor positive advanced breast cancer? That is what we are going to discuss in the next few slides. So if we see there are three CDK4 inhibitors, ribociclib, abemaciclib, and palbociclib. And we have sufficient trials as we have MONALEESA 2, 3, and 7 for the ribo. We have MONARCH 2 and 3 for the abema, and PALOMA 2 and 3 for the palbociclib. And they all have the partner of endocrine backbone, we have aromatase inhibitors, fulvestrant. They've been used in the first line as well as in the second line, and almost all the premenopausal or postmenopausal status. Next, please. And if we see here, the PFS benefit is similar in all, all the trials and all the CDK4 inhibitors have shown a good significant PFS. But what happened to OS? Next, please. The OS was significantly better only with the ribociclib and the MONARCH 2 abemaciclib. The MONARCH 3 is pending, and PALOMA 2 and 3 palbociclib has not shown overall survival benefit. So what is happening to PALOMA or palbociclib? Next, please. Can a benefit in PFS is a predictor for OS benefit also? That is what the next few slides will tell us. And this is what the statistically significant difference in OS when the clinical trials have been challenged. And as with the other targeted therapies, improvement in PFS seen with CDK4 inhibitors have not consistently been linked to OS benefits, as we have seen in the previous slide. Next, please. So if we see the example of PALOMA trial, we've seen the statistically significant PFS advantage in PALOMA 2 and 3, and the hazard ratio was also 0.46 and 0.57. But there was no OS benefit at all. Next, please. So what could be the reason for the differences in PFS versus OS benefit? There have been hypotheses for this. Number one is different patient population in the trial. Number two, the different post-progression treatment in the trials. And number three, the different in the pharmacological characteristics of the CDK4 inhibitors. We'll see one by one. So let's see the first hypothesis, the different patient population in the trials. And that is because we don't have head-to-head trials between the ribo as well as the palbociclib. So they have used a matching adjusted indirect comparison, which is used to compare relative efficacy of the treatment in both the molecules. And they've matched almost all the parameters, the number of patients, the randomization, menopausal status, the treatment arm, the primary endpoint, both are PFS and statistically factors. So almost they have matched everything. And what they found, next please, that the pre-matching differences and the matching, and they have applied the weights to match all the populations. Next please. And they found that the PFS benefit was there, but OS benefit was not there. Next please. The next, the MIC, no, please, previous one. MIC demonstrated significant OS benefit for ribociclib plus letrozole over palbociclib and letrozole. The hazard ratio is 0.68, means there are 32% of risk reduction in the death with the ribociclib. Next, please. Coming to the next hypothesis, that is whether there was a different post-progression treatment trials. Next, please. Next. So if like they have used the one molecule, they have found that pooled analysis of the post-progression treatment after first-line ribo plus endocrine therapy in advanced cancer, MONALEESA 2, 3, and 7 studies. Next. And what they have found, that the use of chemotherapy was less as in the ribociclib arm as compared to the palbociclib arm. The palbociclib arm, they used the chemotherapy in very short duration and very early as compared to the ribociclib arm. Next. And likewise, the extended duration of first subsequent therapy after the ribociclib was very significant. And in all the treatment categories other than chemotherapy or other, the duration of first subsequent therapy was longer with the patient treated with first-line ribociclib versus palbociclib. Next. So in Paloma 3, they have reported similar or numerically shorter duration of next line therapy after palbociclib versus placebo, and chemotherapy was the most common next line treatment after palbociclib. Next, please. So this is what may be the possible carryover effect of ribociclib, leading to the shorter duration of the palbociclib. Next, please. So coming to the preclinical data demonstrates differential activity of these CDK4 inhibitors. So it is a kind of activity we are going to see in all the three CDK4 inhibitors. So what the most important part was that CDK4 would likely to play a more important role as compared to CDK6 in breast cancer. Next, please. And CDK4/6 inhibitors have different differential activities towards the targets. Ribo and abema are the most active agents against CDK4 than the CDK6, not the palbociclib. As it is shown in the graph or the bar, you can see in the orange bar, the light orange 1.3 versus 1. So the CDK4 target was more addressed by the ribo and abema rather than palbo. Next, please. And the CDK4/6 inhibitors, they induce distinct molecular signature in the breast cancer cells. As we have seen, the red dots in the extreme right, that is for the abemaciclib. They have the more interactions with the off-target kinases. And the extreme left, we have very minimal interactions with the off-target kinases as we see the ribociclib. So that gives a more focused action towards the cancer cells rather than a diffuse action for the target kinases. Next, please. And this is the most important one, where they have said the ribociclib achieve the highest level of exposure in the plasma. The free drug exposure normalized to palbociclib very early. You can see it is 1, but it is 27 in comparison to the palbo. It is very, very high and remains in the serum for the longer time. So free drug exposure, what makes it is more efficacious and more cell killer compared to the abema as well as the palbo. Next, please. So all the three all the three hypotheses, they favor and the point towards the betterment of the use of ribociclib. Next, please. Now, with CDK4/6, now the guidelines, we have NCCN, ESCO, and ESMO guidelines. Which CDK4/6 inhibitors is now in the 2023 NCCN guidelines. We see the aromatase inhibitors combination or with the fulvestrant combination, ribociclib is on the top and it is category 1 as compared to the second is abema and the palbo is the last. And they all recommended are the category 2A unless otherwise indicated. Next, please. If we see the ESMO magnitude of clinical benefit scale in the hormone receptor and HER negative metastatic or the advanced breast cancer, the ESMO MCBS is highest with the ribociclib, that is 5 as well as the 4. No CDK4 inhibitor has ever achieved the benefit score of 5. The abemaciclib is also reaching to the 4, but palbociclib is at the 3 or 2 levels. So this is what the score has a rational, structured, and consistent approach to drive a relative ranking of magnitude of clinically meaningful benefit that is achieved with the highest with the ribociclib. Next, please. So do you believe the consistent OS benefit with ribo extend to difficult to treat patient? What do we mean difficult to treat patient is the patient with the visceral crisis, patient having brain mets, and patient with we need a rapid response. Next, please. As the dictum was that if patient has visceral metastasis, we should use chemotherapy first. But this is what we have received the data. And a patient who has visceral metastasis or liver metastasis, even then we have relative risk reduction of death is 19 to 29% with the ribociclib. Next, please. So if the suppose patient develops some kind of toxicity, if you reduce the dose of ribociclib, even then the dose reduction does not impact on the efficacy, as we have seen in the MONALEESA 2, 3, and 7. All the graph with the reduction in doses of 1 or 2 lines, they are superimposed. They did not hamper the efficacy of ribociclib. Next, please. And this is again with the CNS metastasis patients. Next, please. We have seen the patient with CNS metastasis. There was a prolonged time to tumor responses, and the medium TTP was also not reached with the CNS metastasis. Next. So what if the patient who had visceral metastasis also presented with the aggressive disease? So that is excluding visceral cancer. Would you consider ribo plus AI over chemotherapy? What is the evidence in such a group? And which we now have got the evidence. That is, next, please. The right choice study which they have taken the patient with perimenopausal, the hormone receptor positive, HER negative. There was no prior systemic therapy given. A patient presented with aggressive disease, symptomatic visceral disease, rapid disease progression, impending visceral compromise, and markedly symptomatic non-visceral diseases, ECOG performation 2 or beyond. And the ribociclib was used along with the letrozole or anastrozole and the same doses, and the primary endpoint was PFS. Next, please. And remember, this is the first line setting. Next, please. And to see the separation of the graph, it is significantly separated, and we have got the HR ratio, the hazard ratio is of 0.54. It means there was a reduction in death of 46%, and which was not achieved with the chemotherapy, and that too without side effects and the complications of chemotherapy in a patient who is really critical and having the aggressive disease and visceral crisis. Next, please. And this is what the overall response rate, and the time to treatment response is also similar as compared to the chemotherapy. Next, please. So the rapidity of response which we used to expect with the chemotherapy, the same rapidity of response was received with the ribociclib. So to conclude, the ribociclib is the only CDK4/6 inhibitor to significantly improve overall survival across line of therapy, or whatever the endocrine partner or whatever the menopausal status. Ribociclib has also demonstrated consistent efficacy across patient subgroup, including high tumor burden, visceral metastasis, or more than 3 or more metastatic disease site. This was the only CDK4/6 inhibitor who proven twice the benefit of the PFS with a similar ORR response rate as well the time to treatment response compared to chemotherapy in the first perimenopausal aggressive disease patient, as was evident with the right choice study. It is the only CDK4/6 inhibitor recommended by NCCN guideline 2023 as first-line preferred treatment irrespective of endocrine partner. It is the only CDK4/6 inhibitor with proven quality of life benefit and highest ESMO magnitude of clinical benefit score of 4 and 5. And the 3 out of the 3 CDK4 inhibitors, they are different due to their PK and PD profiles, but ribociclib has the highest CDK4 focused activity compared to 6. It is selective as well as the least off-target inhibition. Ribo has the highest free drug concentration in the serum, and it is the potential impact on observed differences in efficacy and safety. So concluding remark was definitely we are getting a cheaper palbociclib, but if we consider the OS as well as the overall benefits, ribociclib is the treatment of choice in hormone receptor positive, HER negative advanced breast cancer. Thank you very much.
Thank you, Shyam sir, for taking the pain you are presenting from a remote location, and happy journey, sir.
Thank you very much. Thank you. So kind of you, Vikas.
Thank you, sir. So now moving to the next presentation, for which we have Dr. Praveen Pariwal. He is a consultant medical oncologist at Bansal Hospital, Bhopal, and he will be discussing about the newer updates and treatment of biliary tract cancer. Over to Dr. Praveen Pariwal.
Hi, good evening. Thank you, Vikas. So can I share my screen? So
Yes, you can do that, sir.
not able to share my slide.
Can you share again?
Is not there.
Sir, should I share from my end?
No, he can share, no issues.
Just a minute.
Yes.
Hi, my slides are visible.
No, not yet.
So it is loading.
Yeah.
So it will be entire screen.
Ankit, is it possible to share the PPT slide?
Just and
Sir, should I share?
just one second. I will try once. So because it is clicking on the
Ankit, if someone is trying, let him give time and try. I know that you can do it very well.
No, no, sir. Just
Yeah. Why you are in hurry?
no, sir.
If someone will not try, how someone will learn?
No, no, sir. Sir is sharing, but I guess some technical issue due to this reason it is not showing.
I can see my slides. So they are visible or not to you, to all. So
No, sir, it's not visible.
okay, just give 1 second, otherwise we'll start. This is entire screen.
Technical team, is there any issue from like Zoom side, or the sir is sharing as
Sir, there is an issue from sir beyond side, beyond the sir side.
okay, okay.
Ankit, you can share from your side. Yeah. Ankit, you can share from your side. I will stop sharing from my side.
Yes, Ankit, please share.
So thank you, Dr. Vikas, Dr. Rajesh, and Dr. Akash and organization for giving this opportunity. We are running late, so I will try to summarize in a few minutes only. So topic for today discussion given to me is new update in the management of first line biliary tract cancer. Next slide, please. So if you see the overall, see the BTC, the biliary tract cancer, they stand on the 4th to 5th most common cancer overall. But in some part of India, like New Delhi, North India, and the eastern part, they are very common, and they are more common in female also. As we can see here, see the incidence and this cancer was kind of static, but it started increasing from the last 2008 or 9 only, and is more common in female compared to the male population. And the unfortunate part is that mostly they are diagnosed in advanced stage only. 90% of the biliary tract cancer, they are diagnosed in when either they are in advanced stage 4 or they're not operable, unresectable. The current standard of care is chemotherapy, the gem based chemotherapy. But with this chemotherapy, hardly the overall survival is less than 1 year only, and the 5-year overall survival is less than 10%. So these results are very dismal. So we want to improve the outcome of this group of patients. So we will learn today what we can do to improve this outcome. Next slide, please. Next slide. So the gemcitabine remain a main drug for the treatment of either the unresectable or the metastatic biliary tract cancer. So till the 2010, it was the standard of care for this group of patients. But in the ABC study 2, the gemcitabine was compared with the cisplatin, that was the experimental arm, and the PFS increased from 5 months to 8 months, gain of 3 months, and the OS increased from 8 to 12 months. But still the OS remain less than 10 years. That means, but this study proved that the GEMS continue to remain the standard of care with the advanced biliary tract cancer. Next slide, please. So one more drug that is very active in the group, the management of this group of patients is oxaliplatin. So this study was published from India only. So what they compared the gemcitabine cisplatin versus the gemox, that is the gemcitabine oxaliplatin. What we can see here, the around 30% overall response rate in both the arm, median PFS around of 4 months, and median OS almost slightly equal in both the arm only. But the both the drugs cisplatin or oxaliplatin, that means can be changed interchangeably. We can use either cisplatin or oxaliplatin. But from a practical point of view, because with the cisplatin, the patient need hydration. So patient who has the renal function deranged or cardiac function or the heart failure, they're more prone. So when we want to avoid the hydration, so we can use the oxaliplatin. On the contrary, but like the patient is having the diabetes and pre-existing neuropathy, where we know the oxaliplatin will cause more neuropathy, we can use this cisplatin. So in that practical sense, we can use either cisplatin or oxaliplatin based on the case-to-case based profile. Next slide. So as mentioned here also, so based upon the ABC2 study, the GEMSIS is the category 1 recommendation. But from a practical point of view, case-to-case basis, there are other regimen also that I mentioned here. We can use either Capox, Folfox, Gemox. We can use the gemcitabine with albumin paclitaxel. So these are one of the combination where we can use if required. Because sometimes when the bilirubin is high, we can use the gemcitabine. So we can use either the capecitabine or the 5-p based regimen. And in some circumstances, like when the patient is NTRK gene fusion positive, we can use either the entrectinib or the liraglutide if available or possible. If the patient is MSI high, we can use the pembrolizumab, or the patient is RET fusion positive, we can use this drug. But these are very rare circumstances. For most of the group patients, we end up using the gemcitabine based chemotherapy only. Next slide. So this scenario change from the this study that was one for that is the durvalumab in phase 3 randomized controlled trial, GEMSIS versus the GEMSIS durvalumab, where the standard of care changed from GEMSIS to the durvalumab. So what is the highlight of this study? We will discuss in the coming slide. Next slide, please. So although we know the biliary tract cancer, they are kind of not so immunogenic like the lung cancer, melanoma, or the kidney cancer, but still this study was designed based upon the positive response from the phase 2 study. So the inclusion criteria were the locally advanced or the metastatic biliary tract cancer, intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and the gallbladder cancer. The cancer that arise from around the ampulla of Vater, they were excluded. Either they have recurrence more than 6 months after the curative surgery, or the last dose of adjuvant therapy were included. Serum bilirubin has to be less than 2, a good performance rate 0 to 1, and there should be more than one measurable lesion by the RECIST criteria. Exclusion criteria, the ampulla of Vater cancer were excluded. So it was a very straightforward 1:1 randomization. GEMSIS up to 6 cycle versus the additional durvalumab that was given every 3 weeks, and followed by the durvalumab was given as a maintenance therapy till the time disease progress. Stratification, recurrent versus the initially acceptable, or the primary tumor location was the patient was stratified, either the intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, or the GBC. The primary endpoint was the overall survival, and there was the key secondary endpoint of the PFS, overall response rate, duration of response, safety biomarker. They were tested in the as a secondary endpoint. Next slide. So these are the patient demographic. So what we can note from this highlight, this slide were unlike the other cancer, the female were obviously similar 50% in this Topaz 1 study. Asian were almost slightly higher, 54%. They were mainly intrahepatic cholangiocarcinoma around 55%, extrahepatic cholangiocarcinoma around 20%, and GBC was gallbladder cancer around 25%. Most of the patients, they were either unresectable or the metastatic, 80%. Around 20% were the recurrent biliary tract cancer. Next slide, please. So we know the kind of the patient who are MSI here, they respond to the immunotherapy. So the MSI status was checked. So it was checked around 50% patient. So it was present in less than 1% in both the arm. And the missing data was present from the 50% both the group only. So we can say, because the data is missing for the 50%, so there was no bias factor for the MSI in both the arm. And the marker that was used for this as response for immunotherapy was the TAP. That TAP is tumor area positivity less than 1%, more than 1%, more than 1 around 60%, and less than 1 around 30%. And the missing data was around 10% only. So next slide. So the patient who received treatment around 100% only all the patients they received the treatment, so there were no default after the randomization. The ongoing treatment at the data cutoff was around 20%. That means around 20% patients they are still taking the durvalumab in the experimental arm versus the around 5% in the chemotherapy arm. And the reason for discontinuation, that the point to highlight, because of the adverse event, they were similar in both the chemotherapy and the immunotherapy arm, around 5%. That means with the addition of durvalumab, there were no adverse event that lead to the disease drug discontinuation. And the patient who received the subsequent indication cancer therapy, as we see in practical sense, around less than 50% patient received the second-line chemotherapy, and the most common chemotherapy regime that was offered for the patient was the cytotoxic chemotherapy, around 40%. Immunotherapy was around less than 1% only in both the arm. Next slide. So these are the overall survival data, the analysis from this Topaz 1 study. As we can see, this curve starts separating after 6 months. The hazard ratio was 0.7476. That means there is a reduction of around 24% in the experimental arm with the addition of durvalumab in the hazard decrease in risk of death around 24%. That is more although the clinical number they sound not very encouraging, around 13 versus the 11.3 month, but what is more clinically beneficial maybe for the patient is, as you can see here, the 12-month OS around 54 versus 7%. That means this around at the end of 1 year, 7% patients there are more surviving at the end of 1 year, and we can see here the data at the end of 2 years. 23 versus the 11 months. That is the more than doubling of patients they are surviving at the end of 2 years with the addition of durvalumab, and the curve remains separating at when the data was then analyzed at the end of 24 months. Next slide. So these are the subgroup analysis. So the primary stratification was based on the location only, as we can see here. So based on this Topaz 1 study, the intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, they get the maximum benefit from the addition of durvalumab. The gallbladder cancer, that is kind of more common in our kind of population, they don't seem to derive benefit from the addition of durvalumab. That is the hazard ratio is 0.9, although the number of patients was still around 20% in this study. The Asian patient, they derive kind of derive more benefit from the addition of durvalumab. The hazard ratio 0.68 versus the non-Asian 0.92. And also the patient who are locally advanced but not the recurrent, they derive the maximum benefit from the addition of durvalumab, kind of the metastatic setting. Although these are the PD-L1 expression either less than 1 or more than 1 doesn't make a difference. So all the patients they get benefit from the addition of durvalumab, either they are the TAP less than 1 or more than 1. Next slide, please. Sorry. And the second endpoint was the PFS. So the PFS also improved with the addition of durvalumab, 7.2 versus 5.7. The hazard ratio 0.75. That means there is a reduction of the 25% reduction in the hazard of progression with the addition of durvalumab. And as we see, with the US data, the 9-month PFS better and the 12-month benefit. So around 10% patient they are still has a progress in the durva arm compared to the in the experimental arm. Next slide, please. So almost same finding that we are seeing with the OS data for this group analysis. The PD-L1 expression doesn't make difference for the PFS also. The intrahepatic cholangio and the extrahepatic they get the maximum benefit from the addition of durvalumab compared to the GVC cancer, and the Asian patient they get benefit in terms of PFS compared to the non-Asian population also. Next slide, please. So the overall response rate, that means the number of patients who are getting response, that means the patient which improve the quality of life of the patient also was better with the addition of durvalumab. Overall response rate is around 26% at the 1 year versus the 18%. That is ongoing response with the addition of durvalumab. So the increase in overall response rate was seen with the addition of durvalumab. Next slide. Next slide, please. And the duration of response, that means how long the medicine is working. So as we can see here, the more than 12 months also. So at the end of 1 year, so number of patients they are responding to the drug is around 26% with the durva versus only the 15% with the placebo. That is more number of patients they are in the experimental arm, they are still responding to the drug. Next slide, please. And this slide is highlighting that the patient who get the kind of good response, like the complete remission or the partial remission, the curves remain widely separated. So upper arm, the purple arm with the durvalumab, so patient who get the CR and the PR, and the versus the chemotherapy arm, the who get the CR PR. In that arm also, that means the number of patient, the kind of patient who respond both to the chemotherapy and chemo plus durvalumab, the curve remains separated. And for this group of patient, the hazard ratio is I think 0.67 something, and the patient who doesn't respond to the either durva or the placebo, the outcome for this group of patient, the lower curve, the green in the two green and blue, the outcome is still dismal. So the patient who are responding, they are responding pretty well with the addition of durvalumab. Next slide, please. So the with the addition of any drug, maybe immunotherapy or chemotherapy, the one point that come to mind is it will increase the adverse event, the side effect profile. But with the addition of durvalumab, the side effect, the adverse event that lead to discontinuation were less in the durvalumab arm, leading to death also with the very less than 1% only. Any grade 3, grade 4 immunity adverse event were around 2% in the durva arm versus the 1.5%. That means the addition of the durvalumab doesn't lead to increase discontinuation or death or the any grade 3, grade 4 adverse effect. Next slide, please. So these are the list of side effects that we see with the chemotherapy, also in chemo plus with the durvalumab. What we can see here is the most of the adverse event were related to the chemotherapy arm. We see commonly the anemia, nausea, constipation, neutropenia, and they were manageable with the that we practice in day-to-day life. Next slide, please. So the most common grade 3 event were anemia, neutropenia, and decreased neutrophil count. That are mostly because of because of gemcitabine, and we use the prophylactic GCF and the if required whenever the blood transfusion. So these are the most common side effect with the in the TOPAZ 1 study. Next slide, please. And the immune related adverse event that we commonly see with the addition of any immunotherapy drug, the grade 3 incidence was less than 5%, so 2%, 1%, 1%. So it is the matchable with the other study and the other that we use in other study also. So the grade 3 and grade 4, although any grade where they were around, the most common were hypothyroid related event, hyper or hypothyroidism, the rash or the pneumonitis, but the grade 3 event were hardly anything. Next slide, please. And the patient who has the immunity adverse event, that doesn't mean they will do poorly. So we can see from the studies, the durva plus gemcitabine were associated with overall survival benefit versus the compared to the patient who get the side effect or not. So both have the almost the same benefit, hazard ratio of 0.60 versus the 0.83. Next slide, please. So based upon this study, the TOPAZ 1 study, as we can see here, so the durva plus gem plus cis is the category 1 recommendation in the treatment of primary unresectable or the metastatic biliary tract cancer. Next slide. So from the 2010, so based on the ABC study, GemCis was the standard of care. Now we have the 2023, so where the now new standard of care for this group of patients is the durva plus gem plus cis. Next slide, please. So to conclude, so the durva plus gem plus cis demonstrated a statistically significant and clinically meaningful prolonged overall survival as compared to the placebo plus gem cis. The biomarker status appeared, the durva plus gemcitabine appear to be effective across the molecular landscape of the biliary tract cancer. The PD-L1 expression doesn't matter, either the less than 1 or more than 1. The durvalumab did not add to the additional toxicity to the seen with the chemotherapy, and the non-safety signals were identified. And the durvalumab at the Imfinzi, the 1500 milligram in the combination with chemotherapy is approved in adult patients with locally advanced and the metastatic biliary tract cancer. And that is now has become the new standard of care for this group of patients. Thank you.
Thank you, sir. So basically what I can understood that the patient at tail end, the benefit most, but unfortunately we don't know how to identify these patients. So moving on to the next presentation, I will be presenting two important abstracts from WCLC of this year. So I think Dr. Akash has already presented, but I will just give my, my take on this FLORA2 study. I will not be discussing in the details. So the incidence of brain mets, you can see, if you see the data, the incidence of CNS metastasis at upfront is in the tune of 40%. So definitely, I think we need to do much more investigation, which should include the MRI brain with contrast to identify these patients who has upfront brain metastasis, because we have something to offer to this patient. The second, that people argue that if we give chemotherapy plus osimertinib, the patient need to be on pemetrexed till progression. So it is not the case. If you see the patient disposition in this chart, at the data cutoff date, you can see hardly 1 out of 4 patients is receiving pemetrexed. So even if you stop the chemotherapy, pemetrexed, if the patient is not tolerating, the benefit remain the same. The second is definitely we have already discussed the benefit in the patients of in the brain metastasis. So I think this is, you can see the hazard ratio is less than 0.5, definitely impressive. And I think we are good to go with this regimen of osimertinib plus chemo in the patient who has stable brain metastasis. The last point about this study is that if you see the forest plot of FLORA trial and you see the EGFR mutation of L858R, there the hazard ratio was 1. So this was the topic of the controversy or the discussion whether you will offer osimertinib to the patients of L858R. But if you see the FLORA2 data, when the chemotherapy was combined to osimertinib, the regimen is equally effective in L858R as it is effective for exon 19. So I think that discussion is over when you add chemotherapy to the osimertinib. So this is my take. And the second important abstract is about the mechanism of resistance that these patients develop on osimertinib, and the study was INSIGHT 2, in which the patients who receive upfront osimertinib and when they progress, the mechanism of progression was tested based on the NGS. And as we know that the most common mechanism of resistance is MET amplification. So it was tested by FISH on the tissue and also by liquid NGS. And they were able to prove that if you add MET inhibitor to osimertinib, continue osimertinib, there was a good response in the tune of around 50%. The response is deeper, and you can see that this is the subgroup analysis. And this is basically a small study, basically thought-provoking study, and we can get a meaningful PFS and also OS. So patients who are progressing or osimertinib, we should always try to find out the cause of resistance, why patients are progressing on osimertinib. If patient is having MET amplification, we can very well continue osimertinib and we can add MET inhibitors. So again, the same data in Asian patients from the same trial, and also that the CNS metastasis, if this patient develop and if the mechanism of resistance is MET amplification, if you add the MET inhibitor, the CNS response was also achieved. So, and also this is the important that if you add topotecan and if the mechanism of resistance is only MET inhibitor, these patients respond well. So this is the conclusion that in the primary analysis of this study, the overall response rate is around 50%. The median duration was around 8.5 months, median PFS 5.6 months, and median OS 17.8 months after progression on osimertinib. So I think this is also a thought-provoking study, although the large studies, phase 3 trials are required. So thank you so much. This was the last presentation. And at the last, I will request Dr. Akash to give the concluding remarks. Dr. Akash, you are there?
Hello?
Yes, you are audible.
Thank you, Dr. Asati, for this opportunity. Thank you, Astra and Novartis, for partnering with us. And thank you all speakers It was a wonderful academic feast, and I hope we have such events at regular intervals. Thank you, Asati sir, and thank you, Horizon, for partnering. Thank you.
Thank you, Vikas sir, Akash sir, and Rajesh sir, and all the esteemed faculties for this informative webinar. Thank you all the pharma for making this webinar successful, sir. Thank you, sir. Thank you, everyone.
Yeah,
Okay,
thank you,
thank you,
everyone.
Ankit.
Yes.
Technical team, you can stop recording.